Hello everyone, this is just a very short YouTube clip to help you with your pre-activity for this week on lung SGL. As you've probably gathered, with every SGL we have a little bit of evidence base that we try and slip in, evidence-based medicine. And the bits we want to introduce in this SGL is about question type, study design and levels of evidence. So I thought we'd do a short YouTube clip that might be a good way to help you do with your pre-reading for that topic so you can get the most out of it. So when you read a paper, there are 6 steps to reading a paper. You've got to know the question type, the study design, what's called the PICO of the paper, or variation on the PICO, depending on the study design. Then you've got to know whether you trust the results within the paper, so the internal validity. We've got to focus in on what the results are, and then you've got to decide are those results going to help you look after your patient, which is the external validity. So they're the 6 basic steps. And we're going to focus on these first 2, study design, question type and study design. So you might ask yourself firstly, well, what do I mean by question type? And I guess what it means is there are different types of questions that we ask. I'll just show you the next slide so you can fresh up what I mean. Some questions we have are related to treatment. Is one treatment better than another? We call those treatment questions or therapy questions. Other questions are diagnostic questions. How does my ISTAT compare with a full blood count in terms of sensitivity and specificity for, say, I don't know, children with anemia in my Indigenous community? What might be a prognostic question? How does a person who's been newly diagnosed with Alzheimer's compare with a person who doesn't have Alzheimer's in terms of how long they survive? And then there might be etiology questions such as do PPIs cause gastric carcinoma? Now there are other question types as well, but just for the sake of keeping this fairly short, I'll just focus on these particular ones. The point about the question type is that different study designs will answer different question types better than others. So certain study designs are better suited to answer certain question types. So, for example, with an etiology question, like does PPI cause gastric carcinoma? Near the top is the prospective cohort study, and above that is a systematic review of prospective cohort studies. Whereas for a treatment question, the top of the tail is a randomized controlled trial, or better still, a systematic review of randomized controlled trials. So the point I'm getting at is that randomized controlled trials is not the best way to answer all your questions when you're looking at the best available evidence. It really varies with your question type. And similarly, if we think beyond these 4 questions, if I look at some of the other question types out there, one of them might be questions on why do people do certain behaviours, or what are their attitudes or beliefs. And the best types of articles to answer that, the best type of study design would be a qualitative research. So I guess the point is just to get that concept that your question type is important because it tells you what study design is best suited to answer your question. And from this concept is how we arrive levels of evidence. So you can see here across here, if I could just put a little pointer up, that for an etiology question, a cohort study is level 2 evidence, if it's a prospective cohort study, that is, for an etiology question. The same cohort study would be level 3 evidence for a therapy question. So you can see how, so this is a useful slide to have because it gives you an idea of levels of evidence and wouldn't make a useful question from the college point of view. So the other thing so the study design. How do you actually work out what study design a paper is? It's another thing that you can get asked when you look at a paper. Sometimes it's not straightforward. And this little flowchart I think is kind of useful in that regard. Basically, it asks this question: did the investigator assign exposures? In other words, did they actually introduce an intervention? Did the actual investigators do it, as opposed to they're just observing something that happened? And if that's the case, then it's an experimental study. And then you just got to know, were the patients randomly allocated or not? And that helps you work out whether it's a randomized controlled trial or a non-randomized controlled trial, of which there's several. If there was an intervention, then you just want to know, is there a comparison group? So were they comparing one thing with another? You know, PPI versus no PPI for gastric carcinoma, Alzheimer's versus no Alzheimer's for prognosis question, a treatment versus no treatment for therapy question, and a diagnostic test versus a gold standard test for diagnostic testing. And if the answer there isn't, then it's a descriptive study. So for example, if I just want to know what's my pap smear coverage rate in my health service, I'm not comparing one thing with another. I just want to know something in time, place, and person, and that's they're going to be that'll be a descriptive study. So if for those who are familiar with PICO, P-I-C-O, if there is no I and C when you're looking at a paper, it's going to be a descriptive study because the I and C is the comparison group, isn't it? Anyway, so if you do have a comparison group, then it's an analytical study. And then it's a case of trying to work out, is it a cohort study, a case control, or a cross-sectional study? And the key thing to appreciate here is that it all comes down to whether you initially selected your patients on the basis of their outcome or their exposure primarily, and then so if you have a look here for a cohort study, that means that when you actually decided who should go in the study, you decided it based on exposure. You got a bunch of people who were exposed and a bunch of people who weren't exposed, who you thought were similar, and that's how you based who got selected in the study. And then you follow them in time towards an outcome. Now that can be retrospective or prospective. You know, you can go back in time to their exposure, then follow them up for their outcome. As long as you start with the exposure, that's really what defines a cohort study. Cohort means March. So that's a cohort study. For a case control study, what you really want to know is, okay, when they selected which patients should go in, was it on the basis of their outcome versus and a control outcome, that, you know, whether the outcome didn't occur. So basically you get a bunch of people who had the outcome and a bunch of similar people who didn't have the outcome. And then you go back in time to see the exposure. So these are always going to be retrospective, but whereas a cohort can be retrospective or prospective. But retrospective mean going back in time. Prospective mean you actually collect information from the start of the study. So if you're if your selection is by the outcome and you're going back in time to the exposure, that's a case control study. And then a cross-sectional is where you have an exposure and outcome at the same time measured. So if I said in 2016, I'm going to ring up, let's say I just rang up a whole bunch of people and said, okay, have you got asbestosis exposure? And they say yes, no. And I say, have you got a mesothelioma? And they gave yes, no. Okay, on that particular day. Well, that's a case control. So in effect, the exposure and the outcome being measured at the same time. So that's in a nutshell how you tell what study design a paper is. It's a nice little flow chart. So I'm just going to quickly test what you've learned by just giving you a few examples. So let's use the example of asbestosis. We know that exposure to that causes a very rare cancer called mesothelioma. I think the knowledge of this from best available evidence has saved many lives. So it's quite a good example of good plug for best available evidence. And let's presume it's quite a rare cancer. It is. It's about 1 in 100,000 diagnosed per year, or a bit less than that. And for each of these examples, I'm going to give you a bunch of made-up study designs, and I just want you to, with each of them, to work out the question type, the study design, the level of evidence, and the main disadvantages and advantages of each study design. And what you'll do is you can look at the case, pause the video, and then I'll give you the answer after each one. Let's go very quickly through these. So have a read of this, and I'll meet you at the other end, give you the answer when you unpause the video when you finish reading it. Oh, well, let's see how you went then. So for this one, Did the investigations assign an exposure? No, it was an observational study, so they didn't actually, introduce something to the patients. Is there a comparison group? Yeah, they're comparing asbestos exposure with non-asbestos exposure, so it's analytical. And which one did they select the patients by? It was the exposure. They said we'll go back to people who we're going to put people in the study who were exposed and a group of people who were non-exposed to asbestosis, and then we're going to follow them up in time to the outcome. So therefore it's a cohort study. And then it's a case, I'd like to know whether it's retrospective or prospective. Well, they did the study in 2016. They went back in time to the exposure, and they followed them up to the outcome. So therefore, it's a retrospective cohort study. So that's that. And in terms of, okay, what type of question is this? Well, this is a harm question. Does asbestosis lead to mesothelioma? So it's an etiology question. And I said it's a retrospective cohort study. And going across here, that's level 3 evidence. And and so that's it. And in terms of the limit, what's good and bad about these sort of studies, well, it's level 3 evidence, so it's not as good as a prospective cohort study. There is higher level evidence out there, and it's a pretty rare outcome. So it would have been a lot of patients to be recruited to find a difference in something as rare as a mesothelioma, and yet. So, that's the things I guess I'd say about that study. It's this case number 2. Have a read of the study, and then pause the video, and I'll meet you at the other end. So this study, again, is a cohort study. If you just follow through that flow chart we had for the same rationale. The only difference here is it was prospectively collected. They actually started the study back in 1950 and have just gone and followed these patients up in time, which is a lot more resource intensive. I mean, in comparison to that other study, they would have done the study could have finished it within a month. This one would have taken many, 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 many years. But it gives you that level 3 evidence, and the reason that level 2 evidence, because again, it's an etiology question cohort, so you can see it's a higher level of evidence. The reason it is higher level is because you are prospectively collecting it. A lot of the limitations of these retrospective studies are due to the limitations of retrospectively looking at data that's been collected in the past, because it's seldom that it either involves retrospective stuff either involves questionnaires of patients from now or going back in time to data that was collected not for the purpose of the study way back then when the exposure was being measured. So that's why prospective is better. So that's this one. This is case number 3. Have a look at it. So, and I'll just go to the next spot. So I hope you appreciate this one. Again, there's no intervention. There's investigators not assigning any exposures. It's observational study. There is a comparison group. It's analytical. So in this case, we are selecting patients based on their diagnosis of mesothelioma and a bunch of cases who don't have mesothelioma. So in other words, we're selecting them on the basis of their outcome, and we're going back in time then to see whether they had asbestos exposure or not. So all case control studies are retrospective by virtue of that. And if we go to the next slide, that's a level 3 evidence for etiology. And again, it's an etiology question. So that's level 3 evidence. The problem with case controls is both in the selection of a suitable control, and the other one is the fact that by virtue of being retrospective, it's got the limitations of retrospective going back to find data from the past. In this case, it's questionnaires, so you're going to get specifically recall biases, because the people with mesothelioma are more likely to remember that they were exposed to asbestosis. And then this is the next one. Let's have a think about this one. Hopefully you realize this one again. Investigator not assigning anything. There is a comparison group. But the outcome and exposure being measured at the same time, so it's a cross-sectional study. Incidentally, some of these descriptive studies here are cross-sectional studies as well. There's a lot of these study designs, including cohort and cross-sectional study, can be descriptive studies, but they're done with different purposes. They're not comparing things. So just because something's a cohort or a cross-sectional study doesn't mean it has to be analytical. But anyway, in this case, it's a cross-sectional study, and if you go here, you'll notice that a cross-sectional study for an etiology question is level 4 evidence, and that's because fundamentally you don't know whether the exposure preceded the outcome. That's probably the fundamental reason it goes down one level. And here's the last example. It's a bit of a tongue-in-cheek one, I guess. Pause the video. So in this case, it's an experimental study. They're actually assigning people to asbestos exposure or not, and it was randomly allocated. So you think, oh wow, that'd be great evidence. The problem is, of course, who on earth would ever do that study and get away with it? It's very hard to do a etiology question and ethically actually answer it with a randomized control study. There are some other technical reasons why it's not a good way to go. So it doesn't even get a mention here under etiology. In theory, look, if you had, for example, if the PPIs cause gastric carcinoma, people might pull out all the randomized controlled trials that were done on PPIs and see if pooled data would say that gastric carcinoma was increased. Problem is, it's no longer a randomized controlled trial. You've actually changed it into an observational study. If you've started with the PPI exposure, you've in effect made it a cohort study. So anyway, that's that. So hopefully you found that useful.